Okay, so I'm sure that a lot of you take this call at any point of time. Uh, Please, can you get quickly to the cath lab urgently? So you have no option apart from meeting the call. And this was one of the patients that when I went to see, and this was the situation when they called me. So one of our team was doing a case, and then he finished PCI to the proximal RCA, and then final angio showed this perforation. The hemodynamics of the patient were more or less stable, but slowly having a bit of hypotension and a minimal chest pain at that time. So start by just reviewing the case. This was a 59 years old female, hypertensive, hyperlipidemic, otherwise no risk factors. She had an old anterior MI 2 years before this index presentation, and viability study showed negative viability and LAD by MPI. Then after 2 years, 2 months before this presentation, she had a reappearance of chest pain with infralateral T-wave inversion. And as we said, the DSE again was non-viable for the LAD and ischemia in the RCA territory. This here was her left coronary angiogram, total occlusion of the LAD at origin with no viability. Otherwise, the left system showed mild irregularities, no significant disease. RCA had a long calcified lesion in the proximal part that was fixed. And I reviewed the film when I was there in the initial part. During the PCI, you can appreciate the wire is nicely folded in the distal RCA. But as the operator proceeded in the intervention, you can appreciate here the wire started to have a bigger loop in the distal RCA, and this probably is the reason why the small vessel dissected. So this was at the end in another view. Again, these are the steps of the intervention, and this is the final that I showed you. First, we have to figure out where the perforation is going, and I'll leave this for you to imagine and to try to figure out. This is a very small branch of the distal RCA at the crux, so maybe this is going somewhere in the inferior septum and the posterolateral wall. But it is not going to the pericardium because an echocardiography showed no perfusion at the time. We had great difficulty to try to wire this branch because it was a mesh of branches at this particular segment, and it was very difficult to selectively wire this branch despite several projections. But finally, we can get to the culprit vessel for perforation. We started with the usual maneuvers, prolonged balloon inflation at the ostium of this small branch with the wire with the balloon for 30 minutes. And then after the 30 minutes, still the perforation is there and it increases even. So you can see the flow is increasing. Again, I tried a more proximal prolonged balloon inflation for another 30 minutes, but the situation is the same, and you still have, this is how the balloon, while inflated, no other perforation, but still. So the questions come here. This is a very small perforated branch with failed balloon inflations 2 times each for like 20 to 30 minutes. The leak is not that small and causing some moderate hemodynamic affection. And because of the situation, anatomical site of the perforation, there is a risk of increasing intramyocardial hematoma. So the option, as we all know, coils and microcoils, as we heard yesterday, fat, collagen, foam, detachable balloons may be considered. Stent graft to the main vessels, although this will close a lot of branches because it is at the site of the origin of many branches. Some authors tried alcohol injection, but this will cause a massive myocardial injury. And these other options are all very time-consuming and very costly at some times. Or we have to think of something else. And because the title of the session is to get out fractured equipment, I propose doing the other way around. We fracture some equipment and put them in the coronaries. And this is how I went to. This is what I called a half balloon embolization technique. I called it a HAPIT technique. This is a property of our team. So here you can cut any used balloon, the size of which, according to the size of the vessel, you cut the balloon between the two markers, just in the middle. And then you load this distal part of the balloon, same direction as the regular balloon over the wire. So you have basically half balloon with the shaft, and the balloon itself is doing like a basket. And then you can push this with any other thing, maybe other balloon, because then you have one marker from the initial balloon and two markers. So you have three markers. You can see it on the screen, and you can push the half balloon to the distal artery. It's very cheap, very handy. You have this in every cath lab. And this is how we did it. This is, you can see the three dots here. This is for the distal. Distal one is for the half balloon, and the proximal two markers for the proximal balloon. And you just push it until you reach the distal perforation. At the crux, I had some difficulty, so I used a body wire to facilitate the passage. And with the usage of a body wire, it could be introduced to this very small balloon. And this is after removing. You still have very minimal flow. And of course, at that time, till that time, we didn't reverse heparin, but at that time, we started to reverse heparin and leave it for that. This is the rationale. If you put a half balloon, it looks like a basket, and it can cause also a coil-like action to induce thrombosis, and can be delivered safely and left in the leaking branch. This is after, at the end of the procedure, minimal leak around the balloon. And this is after 24 hours. There's absolutely no leaks, no pericardial effusion, and the small branch is completely sealed. And this is to remind you how it was in the beginning at the case. I introduced this technique and presented in the PCR 2015, and it was used since then. And it was only recently when Dr. Mohanad Erget group published a similar case, and in like 2021. So my take-home message to you, my dear colleagues, is that hydrophilic wires sometimes sneak, and they can cause a leak. A very small vessel may cause not as a small problems, and what we call half balloon embolization technique or habit technique provides new application for readily available equipment, and can sometimes save both the patients and the interventionists. And as Dr. Feki said, there is nothing called simple PCI, even until the patient goes home. Thank you so much for listening.